لأنها مش على كل الكارديوفاسكولار ريسك فاكتورز. This is our agenda. As we know, the kidney and the heart are mutually affecting each other, with coronary venous disease ends in devastating cardiovascular outcomes, as well as cardiac disease ends in renal catastrophes. The strong association between the chronic kidney disease and the cardiovascular disease is very predictable for several reasons. First of all, risk factors for cardiovascular disease occur commonly in chronic kidney disease, as chronic kidney disease is associated with an increased prevalence of traditional cardiovascular risk factors as diabetes, hypertension, dyslipidemia. And the patients with chronic kidney disease manifests, in addition to the traditional risk factors, a variety of non-traditional cardiovascular risk factors. And by itself, chronic kidney disease is an independent risk equivalent for cardiovascular disease as diabetes mellitus. Finally, the presence of cardiovascular disease predicts a faster decline in kidney function. And kidney disease يحصل cardiovascular disease يخلي chronic disease يحصل فيه rapid progression where لا يؤدي إلى more cardiovascular and so on vicious circle تنتهي devastating outcome. Coming to the diabetes patients, in comparing the cardiovascular mortality in the general population and diabetes patients, we found the following data. Our young diabetes patients having the same mortality as the very old in the general population. Those in the 30s have the mortality as those in the 7s, 8s in the general population. This means that we have aggressive cardiovascular disease and the fate is very poor in our dialysis patients. About 80% of dialysis patients have some sort of cardiovascular disease, whether ischemic, congestive arrhythmia, and any other cardiovascular disease. But the most frequent structural cardiac abnormality in chronic kidney disease and in dialysis patients is left ventricular hypertrophy. This is present in our 75% of dialysis patients. And left ventricular mass index is a strong and independent predictor of cardiovascular mortality. We have a lot of risk factors for this left ventricular hypertrophy, but the most two important risk factors are hypertension and anemia. The chronic kidney disease does not affect the heart only, but affects also the vascular system. We have two forms of vasculopathies, atherosclerosis, and this ends in ischemic heart disease, and we have arteriosclerosis, and this ends in peripheral vascular disease. And the peripheral vascular disease increases the incidence of left ventricular hypertrophy. These are the vasculopathies which we have. Atherosclerotic occlusive vascular disease. This includes inflammation, venous accumulation, and intimate calcification. And in chronic kidney disease patients, the calcification is very heavy. Fat deposition is very heavy. And we have also the other vasculopathy, which is arteriosclerosis, in which there is increased collagen content and loss of the elastic anemia with secondary fibrosis and primary calcification of the median. And it's extensive also medial calcification. So, in the dialysis patients, we have hypertension, salt and water retention, volume overload, effect of fistula, effect of anemia. This leads to left ventricular pressure and volume overload, ending in left ventricular hypertrophy, either concentric or eccentric. Also, we have vascular remodeling, vascular damage. Besides the presence of secondary hyperparathyroidism, malnutrition, uremic toxins, and the sclerosis effect itself, this leads to overload cardiomyopathy, and this ends in myocyte myocardial fibrosis, and decreased capillary perfusion with both systolic and diastolic dysfunction. The cardiac fibrosis is associated with increased mortality in dialysis patients. The higher the fibrosis area, the higher is the cardiovascular mortality. Unfortunately, the problem of cardiovascular disease starts very early in the beginning of the course of chronic kidney disease, as lower estimated GFR was found to be associated with higher incidence of various cardiovascular outcomes as all-cause mortality, cardiovascular mortality, and hospitalization. And chronic kidney disease, even as the baseline creatinine 1.5 milligram, comes on the list of the predictors of all-cause mortality, preceding patients with diabetes mellitus, preceding those patients who have CABG operation. It is well known that most patients with chronic kidney disease will not progress into end-stage renal disease patients. The likelihood of them who will reach to end-stage renal disease, more than 95% of them will die due to cardiovascular disease. In United Kingdom statistics, they found that out of the 62 million population, there are about 5 million having chronic kidney disease, representing about 8% of the population. Only 6,730 of those chronic kidney patients start renal replacement therapy each year. This means 0.13% of the chronic kidney disease patients start as each year. So the question is why cardiovascular disease is very prevalent in chronic and is very aggressive in chronic kidney disease patients. Because in addition to the traditional risk factors, which is highly prevalent, most of the chronic kidney disease patients are diabetic or hypertensive. They also have multiple non-traditional risk factors, such as, and the list is very long, it's very extensive. We have albuminuria, anemia, inflammation, oxidant stress, endothelial dysfunction, homocysteine, lipoprotein A, malnutrition, thrombogenic factors, sympathetic activity, and insulin resistance. All these risk factors are known to be associated with atherosclerosis. So, atherosclerosis in chronic disease patients is accelerated form of atherosclerosis. We have also arteriosclerosis, which is highly prevalent in chronic kidney disease and dialysis patients. This is characterized by diffuse dilatation, hypertrophy of the large conveyor arteries, and by stiffening of the arterial walls. This comes secondary to the pressure and the volume overload and the hypertension, which is frequently accompanies renal disease. The consequence is that we have isolated systolic hypertension with leading to left ventricular hypertrophy and subendocardial ischemia, which is an independent predictor of overall and cardiac mortality. So, what chronic disease does in the cardiovascular system? It accelerates atherosclerosis, hypertension, heart failure, pericardial effusion, myocardial disease, it induces valvular disease, cardiac arrhythmia, sudden death, besides the effects of the dialysis-related problem. So, in order to prevent the cardiovascular morbidity and mortality in dialysis patients, we should do our best to delay the progression of chronic kidney disease, as the progression of chronic kidney disease is associated with progression of the cardiovascular disease. Also, we should start very early in the beginning of the course of chronic kidney disease to control the cardiovascular risk factors. The leading cause of death in dialysis patients is the cardiovascular mortality. And on top of these causes of mortality comes sudden cardiac death or sudden cardiac arrest. As we see here, sudden cardiac death is highly prevalent in dialysis patients compared to chronic disease and general population. And this process is multifactorial process with some avoidable factors as electrolyte abnormalities, which is common in dialysis patients, as well as chronic volume overload. So, in order to prevent this high incidence of sudden cardiac death in dialysis patients, we should avoid using low dialysate potassium and the rapid electrolyte shift which occurs during dialysis. Also, we should use some drugs as ACE inhibitors, ARBs, and beta blockers, which have the ability to reduce the cardiac hypertrophy and cardiac fibrosis, which, as we mentioned before, is highly prevalent in our dialysis and chronic disease patients. Also, they prevent the fatal arrhythmias, which is common also in those patients with cardiac fibrosis. Cardiovascular risks are categorized in two big categories. The traditional cardiovascular risk factors, which is highly prevalent in our patients, as we mentioned before, as diabetes, hypertension, dyslipidemia, homocysteine, and smoking. On the other side, we have a very long list of non-traditional risk factors, as inflammatory markers, higher inflammatory markers, oxidative stress, age, carbonyl stress, and the abnormal mineral metabolism, which is present prevalently in those patients. The list extends as chronic volume overload, anemia, hyperactivation of both nervous system and sympathetic nervous system, disruption in the balance between endothelin and nitric oxide with vasoconstriction, also the unique vascular calcification which is present in our patients. Coming to the conventional risk factors, we have diabetes and hypertension, the main leading conventional risk factors. This will be discussed separately, but the third one is dyslipidemia. It's also prevalent in our patients. And using of statins in chronic kidney disease patients, stage 1 to 4, is beneficial in delaying the progression of cardiovascular disease. But unfortunately, trials of statin therapy in these patients were disappointing. It were negative. We have 3 famous studies. For this study, Aurora and Sharp study, all these studies succeeded to decrease the level of LDL. But unfortunately, all the studies failed to find a significant improvement in the cardiovascular outcome in the dialysis patients. On the other side, hypercholesterolemia was found to be a significant predictor of this in our dialysis patients. Hyperhomocysteinemia is much more common in dialysis patients than in the general population, as about 80% of dialysis patients having hyperhomocysteinemia. And the investigators suggest that this hyperhomocysteinemia is an independent risk factor for cardiovascular mortality, and if we succeed to reduce the level of homocysteine, we may reduce the cardiovascular morbidity and mortality. But unfortunately, the studies which was done using folic acid therapy did not significantly found that it did not significantly contribute to reduction in cardiovascular disease. Smoking, this is an important preventable cardiovascular risk factor, is associated with progression of early-stage chronic kidney disease, as well as it adversely impacts the remaining residual renal function in our dialysis patients. Smoking is strongly associated with incident heart failure, incident peripheral vascular disease, and all-cause mortality. Smokers also exposed to substantial amounts of cadmium and lead. Smoking causes endothelial dysfunction, activation of growth factors, insulin resistance, and was found to be associated also with microalbuminuria. And the more cigarette smoking, the more is the microalbuminuria. So, smoking is one of the most important preventable causes of cardiovascular disease. And smoking cessation should be an integral part of the management of patients with chronic kidney disease. نأكد على الآن ضروري إن لازم يبطل التدخين عشان يحسن الفيدباك. Coming to the long list of non-conventional cardiovascular risk factors, we will have some examples of these risk factors. Anemia coming on top of the list. Relative deficiency of EPO causes impaired vascular repair and progression of atherosclerosis. And anemia was found to be predictive of morbidity and mortality from cardiovascular disease in patients with chronic kidney disease and patients on dialysis. It leads to left ventricular hypertrophy and dilatation. And the more the anemia, the more is the cardiovascular mortality. Uremic patients have a high oxidative burden. And this oxidative stress has been implicated in atherogenic and cardiovascular morbidity and mortality. A lot of factors lead to this oxidative stress. Numerous factors, and this patient increases this oxidative stress. It may include inflammation, malnutrition, uremic toxins, and the dialysis itself leads to more oxidative stress. Now, coming to the rest of the studies conducted to reduce oxidative stress, aiming to reduce cardiovascular morbidity and mortality. The results were contradictory. زي study showed no benefit for cardiovascular outcome using vitamin E as antioxidant. ولو تفتكر فترة من الفترات كانوا بيعملوا فلاتر impregnated with vitamin E. On the other side, spaceRide demonstrated a beneficial effect using antioxidant as well as acetylcysteine was shown to reduce cardiovascular disease in patients with renal failure. So the conclusion of Yeduki was oxidative stress. This is an important part of host defense mechanism. موجود طبيعي في الجسم وبيفيد الجسم، لكن may play a crucial role in pathogenesis of atherosclerosis and chronic kidney disease in chronic kidney disease patients. And these associations exist between increased oxidative stress, inflammation, and endothelial dysfunction, and this may contribute to increased risk of cardiovascular disease. But unfortunately, the benefit of antioxidant treatment strategies in this patient group remains undefined. مش معروف نقدر نقول ولا لا لحد دلوقتي. On the other side, increasingly chronic kidney disease is being recognized as a chronic inflammatory condition, and in this stage, renal disease has become a prototype of chronic inflammation. لما تيجي تتكلم على مثال للchronic inflammation نعتبر الchronic kidney disease a classic example of it. And inflammation plays a central role in atherosclerosis, where a C-reactive protein is the downstream marker of inflammation. It may stimulate excretion of Y1, induce oxidative stress, and increase the secretion of other cytokines. Elevated C-reactive protein, besides other factors that which have been found in chronic disease patients, are postulated to be mediators of cardiovascular disease. And hemodialysis exposes the patients to the risks associated, يعني hemodialysis process itself بيزود inflammation by using long-term enduring tests, the membrane biocompatibility, the endotoxin leaks through back filtration and infection. This cartoon shows the effect of the cytokine production in various target organs. Unfriendly aerobic milieu stimulates the monocytes and macrophages to increase the production of pro-inflammatory cytokine and decrease the anti-inflammatory cytokine, leading to increased insulin resistance, which with its effects equally increase the acute phase reactants and also has its bad effect on the blood vessels. The C-reactive protein was found to be associated with risk of coronary heart disease, ischemic stroke, vascular mortality, non-vascular mortality in the general population. Also, in stage 3 and 4 coronary disease, it was found to be predictor of all-cause and cardiovascular mortality, as well as in hemodialysis patients. Maya syndrome, as we all know, is strictly related, or very strictly related to cardiovascular mortality. And the more the components of the Maya, the more is the cardiovascular mortality. Chronic volume overload also was found to be associated with more cardiovascular mortality. And the more the ultrafiltration rate, the more is the all-cause mortality. Hyperphosphatemia, as we all know, is closely related to cardiovascular mortality, and also vascular calcification is associated with mortality in dialysis patients. Who should be screened? الكيلو guideline قالت لنا who should be screened. Use modalities baseline ECG of echo, exercise or pharmacological stress echo, and angiography for the patients who need to do angiography. All measures to be done for those patients, all drugs to be taken, and even the invasive management as cabbage and percutaneous coronary intervention should be done in those patients. To conclude, we have high prevalence of cardiovascular disease in this case, renal disease patients receiving dialysis, and this usually constitutes a combination of both vascular and myocardial disease, and is related to both traditional and non-traditional risk factors. And unfortunately, most of these cardiovascular complications are already established and advanced by the time patients